Can everyone hear me?
Yes.
Yes, ma'am.
Awesome, thank you. Lisa, you ready?
Sounds good.
Awesome. So if we could hit record. Good afternoon, everybody. Thank you for joining us. It is Tuesday, September the 5th. We're presenting our cardiac webinar series. We've titled that today, The Journey Never Ends, Highlights and Bundle Implementation and Sustainability. And we're going to be highlighting some of our severe hypertension and cardiac conditions today. Just wanted to go over a couple of things, just housekeeping. If you can please stay muted unless you have a question, if you could raise your hand. We do have some wonderful presentations today. So we're going to be pushed for time in the 1 hour allotment that we have. If for some reason we do not have time for question and answers, please feel free to put those into the chat. We will get the presenter to answer those and we will get back to you if there is not time. Just some quick, I'm going to share my screen here. And just some real quick updates that we like to go through. So give me just a second to get all that up and running. Can you guys see the slides?
Yeah, we see it not in presentation mode, just the deck.
Okay. Yep. Working on getting that up and hang on just 1 second. How about now?
We just see not the in presentation mode. And I'm happy to share mine if that makes sense.
Hey, Amy, try F5.
How about now?
No,
Nothing?
it's out just sharing. It's just showing that. So you might need to stop sharing for a second, then select the new screen.
Yep.
And Amy, I'm happy to share my screen too. It's never a dull moment with Teams.
Yeah, Teams is always fun. All right, Lisa, it's struggling over here. So if you want to share that, I apologize for the tech issues, folks.
Sure thing, no worries. And I will advance for you.
Awesome. So we'll run through this real quick. So if we can go to the updates. Our next maternal cardiac update is scheduled for October the 3rd at 2 p.m. Just a reminder that our Q3 2023 hypertension and cardiac data submission is due October the 31st. Also remember that we're always happy to take back data. So if you're behind on anything or have anything that you've struggled with, but now have that together, we're happy to receive that at any time. We continue to work on our Georgia PQC quarterly newsletter. We would love for you to provide us any team bright spots for that newsletter. So any wins that you've had, any patient stories, anything like that, and doing some of your PDSAs, we're happy to have those and spotlight your facility in our newsletter. There's a couple of upcoming things that we wanted to share with you. The Office of Minority Health has a culturally and linguistically appropriate services in maternal health care. Feel free to copy and paste that link and listen to that, as well as a webinar that's being presented by the American College of Cardiology that's coming up in September. So feel free to copy paste those as well as share those with any partners, colleagues, things like that. Next slide. We always like to share that we have our simulation and drills for patient safety under the AIM bundle. So feel free to go to AIM's website, download that information, use it as a resource as you continue to do your work. And next slide is our key driver diagram for our CCOC bundle. Of course, our goal is to reduce severe morbidity and mortality related to maternal cardiac conditions in Georgia. Our SMART aim is to reduce by 20% the harm related to existing and pregnancy-related cardiac conditions through the 4th trimester. And then our key drivers are there: the readiness, recognition, and prevention, response, reporting system learning, respectful, equitable, and supportive care. And then you have your interventions from there. So please use that as a resource as you continue to do all the work that you're doing in your facilities. Next slide. So now I'd like to turn it over to our women's health epidemiology team. They've compiled an enormous amount of data that they're going to share with us today. So I'm going to turn it over to Liz and Christina.
Thanks, Amy.
Thank you.
Hi, everyone. My name is Christina Lamb. I'm a medical epidemiologist at DPH and I'm the lead for women's health epidemiology. And I guess, Lisa, I'll just have you advance the slides if that's okay. Thank you. Here's an overview of the data updates we'll be providing today. We'll briefly highlight severe maternal morbidity, or SMM, among hemorrhage patients, and then we'll focus more on SMM among hypertension patients. Then we'll cover the baselines for cardiac state surveillance measures and outcome measures. And we'll look at where we are with hypertension process and structure measures. And then we'll finally provide an update on hypertension data submission progress for quarters 1 and 2 of 2023. Next slide. This table shows severe maternal morbidity, or SMM, by calendar year and % improvement compared to the baseline for participating GAP-QC hemorrhage and hypertension facilities. This version of the table only includes facilities' hospital discharge data for the calendar year if the facility was participating in the respective bundles at that time. If we look at SMM excluding transfusion among hemorrhage patients in 2019, the aggregate SMM from 52 facilities that were participating in 2019 reached the goal of reducing the baseline SMM by 20%. So hemorrhage went into sustainability in 2021. And so for 2022, all 51 hemorrhage facilities were still seeing an aggregate overall improvement of 10.36%. And if we look at SMM among hypertension patients, we saw really great improvement from baseline in 2020, with the aggregate SMM from 47 facilities participating in the hypertension bundle, seeing an almost 17% improvement from baseline. And on the right, in 2022, with 51 facilities, we're back to about a 5.5% improvement from baseline. Next slide. So this is another way of looking at the potential impact of participation in the hypertension bundle on SMM among hypertension patients. Here we're comparing the time frame of facilities' participation in the hypertension bundle to the baseline SMM. For the first gray bar, this includes all 52 facilities' SMM from their first year of participation in the hypertension bundle. The last gray bar on the right is showing the most recent aggregate SMM from the 41 facilities that have been participating in the hypertension bundle since it started 4 years ago. So compared to the baseline SMM in blue, the aggregate SMM from facilities in their 4th year of participation show the greatest improvement in SMM, with more than reduction from the baseline SMM. Next slide. Here we are looking at aggregate SMM excluding transfusion among hypertension patients by quarter. So as with the prior slides, the facility's hospital discharge data for each quarter were included if that facility was participating in the hypertension bundle at that time. If you recall from the table with SMM by calendar year, here you can see where the aggregate SMM was close to the 20% reduction from baseline goal in 2020. Next slide. This slide shows the aggregate SMM excluding transfusion among non-Hispanic Black hypertension patients by quarter. Overall, it's fairly similar to SMM among all hypertension patients, but here with the SMM reduction close to goal in Q3 2020 through Q2 2021, but with a little bit more variation more recently with SMM higher than baseline in the most recent 2 quarters. Next slide. This slide shows the aggregate SMM excluding transfusion among hypertension patients at rural facilities by quarter. And again, the rural facilities hospital discharge data for each quarter were included if the facility was participating in the hypertension bundle at that time. We saw an increase in SMM in 2021, but showed a sustained decrease below the 20% reduction goal for the past 5 quarters. Next slide. So now we'll move on to the cardiac state surveillance and outcome measures. Here we have the baseline SMM among cardiac patients for participating cardiac facilities overall and by race and ethnicity. As with the previous slides, 2022 data are still provisional and we'll update these numbers once they're finalized. But here you can see that Hispanic patients with cardiac conditions have the highest SMM. Next slide. And it's the same for SMM excluding transfusion among patients with cardiac conditions, here again in gray, with Hispanic patients having the highest SMM for the baseline period. Next slide. And the third state surveillance measure is for pregnancy-related deaths due to cardiac conditions. So for 2018 to 2020, cardiac conditions were the leading cause of pregnancy-related deaths overall and for non-Hispanic Black women. This slide shows the mortality rate for non-Hispanic Black women was 3 times the rate for non-Hispanic white women. Next slide. Here we have the baseline term singleton vertex or TSV cesarean birth rate among cardiac patients. The AIM outcome measure is actually for NTSV, and once we have the finalized hospital discharge data, we'll be able to update these numbers to account for first-time births. But here we have the baseline TSV cesarean birth rate is highest among Black cardiac patients in orange. Next slide. Similarly here with the preterm birth rate being highest among Black cardiac patients for participating cardiac facilities. Next slide. So this slide just shows SMM among cardiac patients for participating cardiac facilities, just showing by quarter, and here we have the baseline and just Q1 of 2023. Next slide. Same thing again here, this time SMM excluding blood transfusions among cardiac patients and just the baseline as well and Q1 2023. Next slide. And finally, same here, but SMM for Black cardiac patients. Next slide. So switching back to hypertension, we'll show how we're doing with the process and structure measures and then end with a look at data submission. So this slide shows the education process measures for hypertension facilities that have reported data. For these measures, we want to see them increase with the goal of achieving 80% or greater. So for Q2 2023, Nursing education for preeclampsia and nursing equity education have reached 80%. The ED provider and nursing education, which is in light blue, is a newer metric that looks to be increasing. However, there's lots of room for improvement with the provider equity education, which is the darker orange. Next slide. Here we have the hypertension structure measures. Sorry, I'm ahead of you. This is for the management and treatment process measures. Sorry about that. You could go back one, Lisa. Thank you. These are the process measures that are related to management and treatment. And you can see that treatment with magnesium sulfate, which is in orange on this slide, has reached 80%. And timely treatment of persistent hypertension has been improving as well. The newer measures related to postpartum blood pressure checks, which are in the yellow or light orange and gray, have a lot of room for improvement, but as you'll see in the next slides, data submission for these have not been great. So here we have the hypertension structure measures, and for facilities that have reported data, all facilities have implemented the measures other than the patient debriefs, which are in light yellow or the light, or in, sorry, yellow or the light orange, and the ED screening for current or recent pregnancy in green, and both of those are newer. Next slide. This slide shows the percentage of facilities that have achieved 80% or greater for the hypertension process measures, as well as the percentage that have not reported data for the two most recent quarters. So Q1 in blue and Q2 in orange. Looking again at the newer postpartum blood pressure check measures, which are the second and third from the left, as well as the ED provider and nurse education, which is the far right. About 80% of participating facilities did not report data the past 2 quarters. And data for provider equity education in the middle is also not well reported. As many of you know, AIM switched to a Likert scale for the structure measures Q2 of 2022. Here we have the percentage of facilities that reported being in the process of implementing or have implemented the hypertension structure measures. So that would be greater than 1 reported on a Likert scale. And again, the newer measures of the patient debriefs on the far left and the ED screening on the far right are the only measures that some facilities reported not having implemented yet. However, overall, greater than 70% of facilities are not reporting structure measures. Next slide. And so this last slide summarizes overall data submission for Q1 and Q2 of 2023. We had 40% of the 50 participating hypertension facilities submit data for both quarters. However, 54% did not report at all. And a handful of facilities reported 1 quarter, but not the other. And that's all we have. Here's my contact information as my colleagues who helped with the data and slides. And we're happy to either take questions now or at the end, however, Amy and Lisa, you prefer.
Are there any questions for Christina after the presentation of the data? Feel free to add those in the chat if you think of anything as we go along. Wanted to introduce to you Shane Reed. Shane's an improvement advisor for the Georgia Perinatal Quality Collaborative. He has over 9 years of quality improvement experience within healthcare organizations and attained his master's in healthcare administration from Georgia Southern University. He also holds a Lean Six Sigma Green Belt from the Institute of Industrial and System Engineers. Shane began his career as an Institute for Diversity intern through the American Hospital Association, with much of his work focused on reducing health disparities in the Macon area. He is currently the manager of accreditation and licensure for a 600-plus bed hospital in the metro Atlanta area. Please welcome Shane Reed, our Georgia Improvement Advisor.
Hi, good afternoon, everyone. So today I wanted to talk through some QI sustainability, some social determinants of health, and respectful and equitable care. Some of the information that I've gained over my years of experience, as well as what I'm hearing from the touch bases that I'm gathering from you guys. And at the end of the day, the front line is where we get most of our information from. So I do appreciate you guys for sharing that information with me. Next slide. So based on some of the things I've encountered, we wanted to go over what does hardwiring mean, and what does that mean for your organization, and how do you know if something's hardwired? Hardwiring is a term that can simply be explained by consistently completing an expected action. These actions are often associated with a process. In healthcare, the hardwiring of a process is validated through the compliance rate of what is being measured or improved. An example for that many of you are aware of is your order set compliance regarding your hypertension bones or anything regarding hemorrhage. A key element needed for successful hardwiring is the education of people on the why. I do try to spend a lot of time with trying to get people to understand the why, because that action usually takes place always for every patient every time. Once people understand the why, you really don't have to go through anything else outside of that. Once they understand the why we're trying to reduce these healthcare disparities, as well as the importance of it, a lot of times the actions always follow. Next slide, please. So based on what I just stated, I would like this to be a little interactive. So you could put the answer A, B, C, or D inside the chat. So which one of the processes below would be considered the most hardwired? The staff usually participates in peer interviews when the department hires new employees. That's A. B, the staff rarely reports incidents into our electronic complaint and grievance log. C, the staff always verifies the name, and I see them coming through. Yes, C is the correct answer, and I'm glad that we were able to get those answers in. And from talking with the organizations, you guys do understand what hardwiring is and what it takes to be a hardwired process. So I do appreciate that. I wanted to have something a little interactive today, and I appreciate your responses. And for C is, and for the answer to why C is the answer to that one is because the staff always verifies the name and date of birth of a patient before giving a medication. And like on the previous slide, for every patient, every time, there are nobody that goes through those cracks. So we want to make sure for safety reasons and to make sure that everybody is getting what they need at the front line. So always is what we want to look for when we're talking about hardwiring. Next slide, please. So this is a slide that I helped create over my time working with, we're trying to reduce healthcare disparities, and it does a great job of kind of informing everybody of what we're talking about when we talk about health equity and what does that mean versus equality. You know, sometimes people say, well, we want everybody to have equal care, but that's not always what that means. Equality versus equity. So if you walk with me through this infographic, as you can see from the far left, you see somebody that's in a wheelchair who presumably does not have the use of their legs at the current moment or is not able to ride that bike currently in her current state. From there, you see that same bike that gets passed on to a taller individual who, as you can see, may need bigger accommodations due to his height. And then you have that same bike that goes to a female and a female that it's adequate for her height, and it seems like it's a comfortable ride for her. But then, as you can see, that kid in front of her, it's not a comfortable ride for him. He may need a smaller bike to accommodate his height and his age. So equality in that aspect is giving everybody the same care, giving everybody the same thing without being prescriptive in it. So as you move to the equity portion of the infographic, you see that same individual that was in a wheelchair now has a bike that she's able to operate with her arms instead of her legs. That same taller individual now has accommodations of a bigger bike to better to go with his height. The lady still has the same bike, which was already accommodated for her, and then the child has a smaller bike to better fit him and be more safe for him as well. So whenever we're talking about equality versus equity, always keep that in mind. Just because we give everybody the same care does not mean it's prescriptive to what they're dealing with at that time, or what they have dealt with in the past, or what they would deal with in the future. So I just think this was a great way to kick off the next couple of slides that we were discussing regarding health equity and some of the things I've heard and seen across my years. Next slide, please. So when we talk about social determinants of health, we want to understand, what are they? Pretty much, social determinants of health are non-medical factors that influence your health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of their daily life. Addressing differences in social determinants of health makes progress towards health equity, a state in which every person has the opportunity to attain their highest level of health. That is our end goal, to make sure that every person that we care for can attain their highest level of health. Social determinants of health have shown to have a greater impact on health than genetic factors and access. A great way to address social determinants of health is to collect data on this using a social determinant of health screening tool. We have social determinant of health resources, including screening tools, available at the Georgia Gap QC Social Determinants of Health website. That is hyperlinked right there. It's also located on our team site that many of you do have access to. And if you don't have access, please let us know, and we'll work to get you that access, because they do have a lot of great resources there, for if you're in the early stages or whatever stage you are in regards to trying to implement this into your EMR. On the next slide, you will see that here's an example of a social determinants of health screening tool within the EMR. It goes through the factors. As the patient would do, would you like to be connected to resources regarding whatever is identified? And then you have a series of questions. This is an example, and it can be tapered however you would like to be tapered based on what conditions you may be seeing in your community. And you want to make sure that they're all very prescriptive to what you're seeing, and really focus on your resources to figure out what questions do we need to ask in our community to make sure it's beneficial to them, and that you can provide the resources that is needed for the community. Also, on the resources website, you have comparable examples from what other organizations have done that have tried to implement this and have done successfully as well, and what they have decided to taper and put into their EMR. Feel free to again peruse that and see and use with it and take from it what you want, and also use me as a resource as well. And when our touch base calls, in order for us to see what will best fit for you guys, and where you're at in your implementation process. Next slide, please. To go along with this, I felt like this was a important topic, because I think it was very impactful in my understanding of health equity, as I talked before, equality versus equity, and understanding our implicit versus explicit bias. Um, Implicit bias is pretty much our unconscious bias, and when one's decisions are unconsciously influenced by pre-existing beliefs about a certain group of people. This is done, you're not consciously doing this. This may come from a culture standpoint. It may be how you were raised, and you just don't know you're doing it, right? An explicit bias is conscious bias. It's when one is aware of their pre-existing beliefs about a specific group of people and makes intentional decisions based on these beliefs. Biases are not just racial, but can include the following, such as stereotypes, gender bias, affinity bias, confirmation bias, age bias, conformity bias, name bias, and beauty bias. It is important for us to understand ourselves and improve ourselves in order for us to then take those lessons learned, and improve our communities that we see. So as a kind of an example, I would like to show you this next picture, and just you could put in the chat of what do you think this individual does? What do you think his background is? What do you think what do you think his role in the community is? Be honest and truthful, and it is okay, because this is how we often view individuals that we see. We may not know his parents, we may not know his background, But like you can see, he's an individual that he has tattoos on his arm. You don't know what those numbers mean. So just take an opportunity to just start putting in your chat. What do they do? I see it. I see that, Mary Lou. U.S. Representative. Awesome. Anybody else? Or would you think that this person is, would you assume that this person has had a harder life than others? We also want to go there. Okay, weightlifter, bouncer. Okay, I like those answers. Those are good. Security guard. Exactly. I like those answers. Awesome. Chef, thank you for your feedback. So we can go to the next slide. Okay, we have gang member. And exactly, he is a lieutenant governor of Pennsylvania. And those tattoos that you saw on his arm, on his left arm, was the zip code of that he was mayor over that city for a very long time. And on the other arm were all the area codes that he was associated with. Based on our cultures, we also, we are taught a lot of times not to judge a book by its cover, but that unconscious bias can creep in, and only the way we can actually fight unconscious bias is knowing what we are actually biased against and trying to and not what you were thinking, I know, and trying to address those at the very forefront of our minds, and also giving everybody the benefit of the doubt, no matter no matter what arises, to understand everybody comes from different walks and natures of life, and we want to treat everybody equitably, and make sure that no matter where they come from, what they look like, we want to treat them the same. Absolutely. Okay, next slide. So, no matter where you're at on your health equity journey, doing little exercises like that, just thought provoking exercises, whatever it may be, anything you can gather up to just do with your staff, or little icebreakers, it gets people to think really about their day to day lives and how they can implement it into their day to day work. So, where to start? Connect with one of the following at your organization to understand what is already being done and how the great work you are doing can assist in that. So if you have a diversity, equity, and inclusion leaders or committee, definitely connect with them and see what they're working on, and if they can assist in your efforts. Maybe it can be some more resources, more manpower put towards it. Social workers, what are they doing? What do they see? Does some of the work that you do, does that flow over to what they do as well as care coordination? And also make sure you're also looking at your community health needs assessment. Work is currently being done, and how is it being addressed by your organization? The more things that we're aware of, the better we can serve our communities to really reduce those disparities that we're seeing in Georgia. Next slide. And so that previous slide was very important, based on, I don't know, organizations may be Joint Commission accredited, maybe DNV accredited, but there is a push from CMS as well, which is why they're doing this, to really reduce those disparities and really focus on what are you doing around health equity. One of the national patient safety goals is to improve health equity, and this was effective July 1st, 2023, and it's really under the leadership standard. I know I may be speaking, accreditation or regulatory, but this is really the why of why a lot of organizations have decided to then implement a director of diversity, equity, and inclusion, and really get that push going to really address those disparities and get organizations to push forward with really seeing what they can do for their communities and meeting them where they're at. So with these committees, remember that this is going to be a standard in the future, and this could be that ammunition that you need to really get them to focus on the disparity reduction that you're working on right now. Next slide. So again, they're required to do the following. This is a better summation. The last slide was more of the actual standard that will go with it. So this is a little more digestible. They're asked to identify an individual to lead activities to improve healthcare equity, which is why they are hiring directors and managers of DEI. Assess the patient's health-related social needs. This is being accomplished by most organizations completing their community health needs assessment. Analyze quality and safety data to identify disparities. Now, this part of it is where organizations are kind of struggling to really get that data in regards to where they want to focus their attention at. And of course, you may be constrained by staffing in order to do this, but they are in the early stages. And develop an action plan to improve healthcare equity. Take action when the organization does not meet the goals in this action plan, and inform key stakeholders about progress to improve healthcare equity. These are new standards that went into effect this year, so there are early stages. I know prior to the implementation of these standards, they were asking organizations, "What are you currently doing in regards to health equity?" Even though it's not a current standard, they just wanted to see and get a barometer of how organizations were trying to address it, and any great learnings they did learn, they shared with other organizations that were also accredited with them. Next slide. So that ends my health equity portion of it, and hopefully, yeah, I gave you some good tidbits to take away. And I wanted to go over a quick coaching overview of kind of what I've been hearing from my touch bases with organizations. One of the most common barriers, or some of the most common barriers, were ED order set initiation for hypertension. That's kind of been a barrier in regards to compliance. The staffing challenges, of course, making sure you have the people to do the work and also gather the data and as well. Physician order set usage, again, and ongoing education. A lot of these barriers is why I wanted to mention, if they understand the why behind what they're doing, a lot of times the actions will follow. But of course, you have other constraints that go into that as well. So my coaching sessions, we talk about the barriers, successes that you're going through in regards to your initiatives, any PDSAs you're working on, any shared learning that I could share with other organizations that I meet with. So the more shared learning that I receive, I also make it my due diligence to try to share with other organizations of like size. No matter if you're a 600-bed hospital or if you're a 300-bed hospital, I try to share what matches with the resources that you have in those areas. And if you want to schedule any coaching sessions outside of the times I've already scheduled with some of you, you can see my email right there at the bottom, shane.reed@dph.ga.gov. And I'm very flexible in the scheduling. I usually don't take more than 30 minutes. And then if we need more time, we touch base more often, we can do that. But I really want to hear what work you're doing, and so I can share with other individuals, and also be a resource for you for any future endeavors you may have. I think that was all I have for you guys. If you have any questions, let me know.
Thank you, Shane, so much. That was a great presentation. And again, if there's any questions, let us know. If you're not comfortable, just put those in the chat and Shane can get to you, or we can get those to Shane and he can get back to you. Thanks again. Our next two speakers are from Augusta University Medical Center. First is Carla Allen. Carla has 18 years of experience in perinatal and neonatal nursing. She received her BSN from the Medical College of Georgia and her master's from Western Governors University. She's certified in executive nursing practice as well as inpatient obstetrics and electronic fetal monitoring. She's currently serving as the Administrative Director for Cardiovascular Services, Wellstar MCG Health. Carla is a member of the Augusta University Medical Center Maternal and Infant Outreach Team, serving as the data analyst for Georgia PQC Metrics. Carla has been a member of Georgia AWAN since 2006 when she began her nursing career. She served as the Augusta Area Chapter Leader, the Secretary-Treasurer of the Georgia Section, and most recently as the Georgia Section Chair for 2022. She's an alumni of AWAN's Emerging Leader Program, which she completed in 2013. Carla is an engaged leader who has demonstrated experience in leadership and managing complex units. She has a passion for shared governance as well as mentoring others. And our second speaker is Tasha Charles. Tasha is an RN with her master's degree. She's been a licensed practical nurse for 28 years and obtained her RN in 2018. Following that, she earned her BSN from Chamberlain University and graduated with honors. Later in 2022, she received her Master's of Nursing Education from Western Governors University. She's worked in cardiology and virtual care since graduating from RN school. Her passion is caring for patients and providing them with the knowledge they need to make informed healthcare decisions. She enjoys learning new things and sharing what she's learned with others. Please welcome Carla and Tasha.
Thanks, Amy. You. All right, if you'll advance the slide for us. We're just going to talk about our cardio obstetrics program here at Wellstar MCG Health. That is our new name as of last week. So we are excited with our new partnership with Wellstar. We are formerly Augusta University Medical Center, formerly MCG, formerly Georgia Regents. We've had lots of names in my tenure since 2004. But we are excited to be partnered now with Wellstar here in Augusta. We serve as the regional perinatal center for the East Central region, serving the primary Athens areas of Augusta to Athens and over to Statesboro. So we've got a 22 county region that is mostly rural, with 6 delivering hospitals in the entire region, 3 right here in Augusta within a 5-mile radius of each other. And then the next closest ones are in Athens and Statesboro. So we do serve sort of that care desert that a lot of people hear about. Next slide, please. One of the first things that I like to highlight about our program, not just from a cardio obstetric standpoint, is our OB emergency department. It was established in FY19. Initially, we started out serving those patients 20 weeks to 6 weeks postpartum, and now recently they've dropped that gestational age that they're seeing in the OB-ED down to 14 weeks gestation. Again, to 6 weeks postpartum. One of the things that Dr. Chad Ray and I really wanted to emphasize when we started that program in July of 2018 was that we saw those women who were postpartum that our ED was missing preeclampsia on. We were constantly having issues where women were being misdiagnosed with, oh, you're just tired, that's why you have a headache, or their blood pressures weren't a high enough threshold, and we would see them again later because they'd had a seizure, or we were seeing them in the office a day or so later with really increased blood pressures at that point. So it really was important to us to grow this program and see those postpartum women, and that has successfully grown from seeing about 7 a month to now they're seeing somewhere between 20 and 30 patients a month in that postpartum period. We've seen over 3,500 patients in the OB-ED in FY22 alone, and 20% of that population was postpartum. Next slide, please. Another thing that we did as early adopters prior to starting the cardio obstetrics program here at AU was we implemented the modified early obstetric warning signs, or MEOWs. This is not only embedded in our documentation system, and we use Cerner, but it also is in our Philips MP5 monitors. So the monitors that are your vital sign, you know, your Dynamaps is what everybody calls them, even though they're not. Dynamap is the brand anymore. It allows for immediate recognition by the PCTs who are doing these vitals that they need to get somebody involved. The primary RN immediately needs to be notified of whatever vital sign is out of range on here. So, and it gives them exactly what to do at the bottom, that they notify the primary RN of the results, to include pain and urine output. And we emphasize to them why they need to do it and how frequently things need to be reevaluated. This has really helped us get our PCTs, who again are out there doing our vital signs, more engaged in that immediate notification of nursing staff. Next slide, please. So program development, we know that we have a unicorn program here at MCG with Dr. Sharma, who is our cardiologist. This was actually sort of his idea. He was out on medical leave, went to a conference remotely where they focused on cardio obstetrics, and came back and told Tasha, who was his nurse at the time, about this idea that he had. Went to Dr. Chad Ray, who is our head of obstetrics here at MCG, and said, hey, I really would like to partner with you. And Dr. Ray was like, hey, I've been looking for a cardiologist to partner with. And so this partnership was sort of made, you know, out of nowhere. We know we just finished the A1 conference last week when Tasha and I went, and there were about 80% of the people in the room there who biggest struggle is finding a cardiologist to partner with them. This program started a year before the GAP QC metric relative to the implementation of cardio obstetrics did, with a 1 half-day session per month, seeing those women that were postpartum, for echoes and follow-ups to preeclampsia diagnosis. And again, Tasha started out, she is our nurse navigator for the program, and she started out just as Dr. Sharma's nurse, but found that there was such a need and really kind of dove into the program as well.
Next slide,
Slide,
please.
please.
So like Carla said, the program started off, we were doing a half-day clinic a week. And then we kind of went from there where we started, Dr. Ray introduced the program to the perinatal quality group, and we started getting referrals. He presented it to at grand rounds. We met with our residents. Again, our hospital is unique is that we are a teaching facility, so we have residents, and we kind of gave them what the criteria would look like and what we would want in the clinic, and we grew from there. In fiscal year 23, we were awarded with the DPH grant, and which allowed us to kind of expand on staffing. I was offered the position. I was kind of just birthed into it by Dr. Sharma, and just really found that I really enjoyed the position. And so my position is unique in that I'm Dr. Sharma's nurse, but I'm also the cardio OB nurse navigator. So I am in clinic with our patients every week. I attend the inpatient rounds, and I do the risk stratifications on all of our patients, from the perinatal board round and on the inpatient side. We haven't yet gotten to the outpatient, but every patient that comes in has a risk stratification that I complete. And if they are appropriate, we then, I go in, I meet with them, I give them the information, I set their appointments up, and I follow them throughout the process. We have a nurse practitioner that works alongside of us. We have another physician, Dr. Bethel, who also works with us. She does clinics once a month. So that's a total of 5 clinics that we have. We also partner with Dr. Marlowe Vernon in the population health. We have been referring to her Vita RPM program. We're starting to get referrals into our virtual care at home program, which is a program that allows them to go home. They continue to have physician monitoring. A nurse sees them 24 hours a day. They monitor them. They can do their labs, and kind of just extend that stay from the hospital. And we have created echo slots for our patients as well, so that they can get those things. Because we have, like Carla said, we're like the desert. We have people coming from all over. So to try to accommodate them, we let them get their echoes if it's appropriate the same day as their appointment, so they don't have multiple trips. We work alongside with maternal fetal medicine to try and correlate our visits alongside with those as well. So they may go over and see them, and then they come over and see us. And
so some other things that we'll be doing this year is we're going to expand our telehealth program. We also are going to start a food as medicine program here at MCG, where we are going to be partnering again through the population health side of the grant to offer ways our patients can get fresh fruits and vegetables and those kind of things while they're here for visits. We have a new population health cardio OB nurse educator who's going to be joining our team next Monday. So we're super excited for Sarah to be joining us. The utilization of a mobile care van to take care into those areas to get to our patients. That to me is huge, especially in the care desert that we are serving. And then regional outreach to all OB providers, as well as some family medicine practices for continued referrals and improved referral patterns for our program. And then also we've been invited again this year to do outreach education for emergency department providers and non-delivering providers through our rural emergency medicine program. We'll be speaking at their annual conference in February. And then we also, through the maternal outreach program, program here, our maternal and infant outreach educators are going into those non-delivering hospitals and not just talking about emergent delivery. They also were talking about how to identify hypertensive crisis in these patients and when to refer them out. Next slide, please. So the team, again, it grew from just Dr. Sharma, Dr. Ray, and Tasha, who I'm going to be completely honest, Dr. Ray didn't know about until we were interviewing for this nurse navigator position. And we interviewed Tasha, whose background is cardiology, and we interviewed an obstetric nurse. Last year, about the same time, I transitioned from 18 years of doing perinatal and NICU to this new role in cardiology after being recruited by the previous administrator who retired. And I tell everybody, as many people that will listen to me, because I didn't understand why I did it. And now because of this program I do, I feel like I was able to marry these two things together because, again, so many people are finding the hardship in partnerships with cardiology. And so helping bring that passion here. And one of the things when we were doing interviews that was huge to me is Tasha's background in cardiology and her interest in how to improve maternal outcomes was so evident. And I told Dr. Ray, I was like, she's been in this from the beginning. She has taken initiative to learn. She has really gone out there, and she has a benefit that none of the rest of us do, and that she doesn't know people. So nobody will think she's trying to steal their patients. And I can teach anybody obstetrics. So Tasha has helped us not only to grow partnerships within getting our own patients referred into the program, but also getting our cardiologists to buy in, our NPs, being excited about the program in a space where everybody's already familiar with her is great. But Dr. Monique Bethel's there again. She's one of our cardiologists. We've gotten her tied into one clinic day a month. And then Meredith Saxon, she's our lead NP here for our program. She has joined. And then both of our maternal fetal medicine specialists, Dr. Woodham and Dr. Marr, are both huge proponents of the program and how we're going to continue to grow it as an RPC. So if you're an RPC, one of the things that I wanted to bring forward is if you're having trouble at some of your smaller hospitals getting those cardiology referrals in, as the RPC, going ahead and being the leader and then figuring out how you're going to get everybody to you for your cardiology visits. How can you leverage telehealth? COVID taught us so many things about telehealth and virtual care that there's a way to get that information. Talk about this program, try to get some more.
Carla, we lost your volume.
Uh-oh. Is that better?
Nope.
Let's see. Amy, is that better?
Carla, we can hear you a little bit, but you just kind of went a little soft. So I don't know if you can get closer to the mic, maybe that might help.
It's just very, very faint. It sounds like you're in a tunnel.
That's so weird. I'm going to join from my phone and see if that fixes it.
Yeah, thanks, Jessica. She said, if you're on a headset, see if it might have been disconnected.
Hey, is that better?
Yes.
Okay, I switched to my phone. I think it's something going on with my computer because we were not on a headset. So anyway, just if you're an RPC trying to join in with a cardiologist as the regional center, if you can't, partnering with one that has a cardiologist already involved to utilize telehealth, virtual care, those kind of things to go ahead and get this care out to other people in your area. Next slide, please.
Okay, so just a little bit about our outcomes since starting the program. Like we said, in fiscal year 22, we started and we saw 67 patients. Of those patients, 10 were cardiomyopathy and 8 were preeclampsia. And fiscal year 23, we saw a total of 232 patients. 54 were cardiomyopathy and 58 were preeclampsia. Our remote care milestones, we've referred 26 patients over to population health side, And as of the time that this slide was created, we had did 2 referrals to virtual care. I think we may be up to 4 or 5 now. So we are growing in that area too. And that was one of our very first patients before we were even granted. And we just did a finding solutions on her, and she spoke about our program.
Absolutely. And then the other thing that I'd like to say about some of our outcomes is one of the ways that we've made the biggest impact to get that number from 67 that we saw the first year to 232 in our second year, which was again the first formal year that GAP QC was doing the program, was by hiring Tasha and Tasha going in and doing the risk stratification. You can certainly build that into your models for your EMR, whatever system you're using, whether that's Cerner or Epic. You can build those questionnaires in. The other thing that Tasha did, not only is she going in and risk stratifying everybody and doing that key component, she's made lots of relationships with our physicians that cover labor and delivery and cover our postpartum service here. She's done education with them. They've got signs in their room, so they know also who to do those referrals to. So having active communication with those taking care of your patients that you want referred in is a great way to grow your program. Next slide, please. Okay, and that is the end for us. If you guys have any questions, we're happy to answer those. Or you can also email Tasha and I will add our email addresses into the chat. One of the other things that we did was we got a generic cardio OB at augusta.edu email address set up for Tasha and Brooke Meyer, who's our clinic manager, to be able to oversee. That way our referrals could be a one-stop shop. So that's also something to do. I know a lot of our providers here like that go-to person, that one thing they can always remember that sort of never changes. That way, if the person changes, the actual contact information doesn't. So that's also something to consider as you're building a program. And thank you guys so much for having us today. We really appreciate it.
Thank you.
Thank you guys so very much for sharing all the work that you have done and continue to do. Are there any questions for Carla or Tasha? So like Carla said, she'll put their contact information in the chat box. If you feel like you want to reach out to them offline, use them as a resource as you continue to do the work you're doing in your facilities and your communities. And I just want to thank all of our speakers for today. Thank you, Christina and the EPI team, for presenting on data. Thank you, Shane, for presenting your presentation on the work that you're doing, reaching out for facilities and equity versus equality and the social determinants of health. And join us next time. Our next webinar will be in October, so look for that flyer. Share this with your colleagues. You can always find our other presentations and webinars on our website at georgiapqc.org. So look back on those, and thank you again. Have a great day.